I begin, once again, my name is Nehal Bhatt, here part of the ECHO Hub team for the Medications for Opioid Use Disorders ECHO Clinic and Chief of Addiction Psychiatry here at the University of New Mexico. No financial relationships, no disclosures, and we're gonna be talking about fentanyl, right? And I guess more specifically, what are termed high potency synthetic opioids or HPSOs. Starting with epidemiology, this slide we've gone over recently, so I won't spend too much time in. It's really essentially showing the many waves of the opioid epidemic as it hit the United States. And the take-home point being that really, since about 2013 or so, the line that you start rising the sharpest are those high potency synthetic opioids, right? And that's largely been driven by illicitly manufactured fentanyl. And that's really the kind of the wave of the opioid epidemic we're continuing to grapple with. And some slides here that we had put together as part of the New Mexico ED Bridge project. And really some of the kind of newer data, which undoubtedly many of you have seen, right? CDC releasing this, data showing that drug overdose deaths in the United States topped 100,000 annually, right? Between May of 2020 and April of 2021, which was the highest ever recorded number of overdose mortalities in any given 12-month period, right? And report represented an increase of, almost 29%, right? In compared to the prior 12 months. And it really seemed like fentanyl was driving this, right? As you can see in this red bullet, synthetic opioids, primarily fentanyl, right? Cause 64% of all drug overdose deaths. So almost 2/3 of mortalities involve fentanyl, right? And similarly, we had seen an increase in overdoses involving methamphetamines and other psychostimulants. But very often, the data show that these are found together, whereas fentanyl and methamphetamines present in someone's system, and they get attributed to both, right? So we're gonna focus on fentanyl here today. Initially, when fentanyl hit us, right? Going back to, fentanyl hit us around 2010, 2013, what we found is that primarily the states east of the Mississippi started seeing fentanyl adulterated or substituted heroin, right? Which was basically people thinking they were buying heroin, but what they found was heroin that had been adulterated with illicitly manufactured fentanyl, right? It was marketed as heroin, but it was a whole lot stronger, right? And so we saw the first kind of part of the United States that saw, itself getting hit with fentanyl associated mortalities was really the states in the kind of the East Coast and Southeast, right? And to a lesser degree, the Midwest. But West was largely spared. This was an East Coast, Eastern United States phenomenon. And important to keep in mind that this fentanyl was made in illegal labs. It was not diverted pharmaceutical grade heroin. So this is really showing that, right? So this is looking at regions of the country. And you can see again that the part that starts to rise first, in terms of the overdose mortalities, is this red line, right? Which is the Northeast, right? And also the Midwest, kind of following closely behind, followed by the South. But even when you look at January through June of 2017, so first half of 2017, look what's happening in the West, right? Fentanyl mortalities, they're maybe starting to tick up, but we're not seeing a whole lot of it, right? So it seemed like the West was really spared from it. Similarly, this is really showing data, from Kaiser Foundation, showing that, again, I think this is 2018 or 2016 rather, where, many of the Western states, including New Mexico, are much lower in terms of fentanyl-related mortalities compared to the states here, right? You can see on the eastern part of the United States. So it was sort of seen as a regional phenomenon. But then came counterfeit pills, right? Right around 2018, we started seeing it even here in New Mexico, in Arizona. This is a report from 2019, right? And now we started seeing fentanyl, right? Pills that people think are oxycodone, for example, or hydrocodone, which are in fact illicitly manufactured pills that contain illicitly made fentanyl and its analogs. And right now, at least in New Mexico, for those of us who are in New Mexico, this is what we're seeing, right? This is what our patients are reporting, smoking those blue oxys, which are essentially all fentanyl-containing products. And therein lies the clinical challenge. So now we've seen a huge uptick in fentanyl-related mortalities, even here in New Mexico, of course, and that's the big challenge. So I think for the rest of the time, I'm gonna go into what do we do about it. I think ideally, we want a comprehensive solution, right? If we were to tackle this really well, supply reduction, demand reduction, improved treatment protocols, harm reduction, right? I put here fentanyl test strips. Many of you may be aware that this is a legislation that's currently, in making progress to the New Mexico legislature, which would make fentanyl test strips available, more widely available. And I think it's actually going to be on the floor today, if I'm not mistaken. So we will see what happens, but that potentially could be a great harm reduction measure. And of course, building up community resilience. Now I'm going to focus here very narrowly for the purposes of this echo presentation on the treatment piece, right? How do we appropriately treat this? That's really what we're going to talk about. And Jeanette says, House Bill 52 passed. Wonderful news, Jeanette. I've been, working all morning, so I wasn't aware of that. So thanks for sharing that. And House Bill 52, again, is the bill I was just referring to. So I think we want to expect the unexpected. We want to remain curious. And I think certainly, when we think about February of 2022, if we're not sure what opioid the person has used, if the person isn't sure they're using illicitly obtained pills, then I think we should proceed with the assumption that patient may be exposed to fentanyl, right? I think it's safe to assume fentanyl. Keep in mind, and I know this is something else that's been in the news a lot, but it is important to point out that overdoses, even the ones that involve fentanyl, can be effectively reversed using naloxone. So naloxone, or Narcan, as it's often known, does work just as well, right? Is very effective for reversing overdoses related to fentanyl. However, you may need to provide multiple doses, but generally, despite many reports, people still wind up needing less than 12 milligrams of naloxone, according to literature, to reverse overdoses involving fentanyl. So naloxone still works, still a good idea to tell our patients to carry it, still a good idea to make it available. Second, our treatments work. That's really what the next slide is looking at, right? That, some of the recent studies from 2018 and 2019 show that with both methadone and buprenorphine, they work. They help our patients who are using, fentanyl, right? In terms of opioid reduction, opioid use reduction, in terms of treatment retention. But some patients may either need higher doses of buprenorphine because they simply have a higher level of baseline tolerance, or, right, maybe they need to, at some point, transfer it over to methadone if buprenorphine winds up not offering enough benefit, right, if their tolerance is so great. And with naltrexone, the initiation, the induction may be particularly difficult. There isn't a lot of data on it. And patients may need more frequent dosing, i.e. if they're using, injectable long-acting naltrexone, thinking about an injection once every 3 weeks as opposed to once every 4 weeks. But again, the data is really lacking here. Once again, naloxone overdose works. The key thing is that the time window for success may be shortened. So be sure to call 911. Be sure to continue to make naloxone widely available to our patients, providing education on overdose reversal, right? So now we come to buprenorphine. As the Sarah Wakeman study pointed out in 2019, buprenorphine naloxone treatment retention and abstinence rates appear roughly equivalent, whether someone is primarily using fentanyl or primarily using heroin. So again, it seems to work well. And most people are doing okay with initiations, at least according to literature. But anecdotally, all of us are hearing and all of us are seeing more and more reports of precipitated withdrawals when someone who's using fentanyl takes their first dose of buprenorphine. And this is being reported all over the country. And it's really been looked at. Why does buprenorphine lead to more precipitated withdrawal in patients who are primarily using these high potency synthetic opioids? And the answer actually isn't entirely clear in literature. There are a lot of theories though. including the fact that fentanyl has reduced renal clearance, particularly with protracted use. It's also more lipophilic, so with continued use, it's stored in tissue, gradually released. So the half-life of the illicitly used fentanyl may actually be a lot longer than what's reported in literature regarding sort of pharmaceutical grade fentanyl that someone is using in the setting of pain management, for example. So how do we best tackle it, right? That's what I want to get to. How do we best tackle initiation? What are some approaches being studied? And then what do we do for maintenance? For maintenance, as I pointed out, important to keep in mind that patients may require higher doses of buprenorphine, right? I'll start with that, just a couple of sentences on that. Historically, we used to say that most people need somewhere between 12 to 16 milligrams of buprenorphine, that's a sufficient maintenance dose for most people with opioid use disorder. But some of the newer studies have not found that. And in fact, at least one study has shown that especially early in treatment, patients may actually do better if they're built up to 24 milligrams of buprenorphine as opposed to 16. There is a big multi-site national study about to start that's going to compare doses of 16 milligrams of buprenorphine to 32 milligrams of buprenorphine. And at least the working hypothesis is that the 32 milligrams of buprenorphine will lead to better treatment retention and better outcomes compared to 16 milligrams. And I think a lot of that, again, is being driven by the fact that most of our patients are coming in exposed to fentanyl, which is this highly potent opioid. So they may just be coming in with a higher level of baseline tolerance, right? So keep in mind that you may need to optimize to 24 milligrams of buprenorphine. And for some people, even if that doesn't cut it, they continue to have withdrawals or cravings, you may need to think about methadone, right? And naltrexone initiation may be particularly difficult. So big process. Now, for the next about 10 minutes, let's talk about newer approaches to starting buprenorphine. Starting with microdose approach, which I know we talk about a lot, and really is becoming increasingly common, especially in patients who've been using fentanyl, right? So the idea, the rationale is that you don't, initially withdraw off the full mu agonist that the person may be using, whether it's illicit or prescribed, that the person gets to continue whatever opioid they're using, and you introduce buprenorphine with its long half-life, high affinity at the mu receptor affinity, but only partial agonism, as slowly and gently as possible. That 3 is clearly a typo. So for the next version, I'll be sure to take that out. I apologize. And as buprenorphine is slowly increased, the full agonist is slowly displaced by buprenorphine. So every day, buprenorphine displaces a small amount of the full agonist. So over several days, as buprenorphine dose builds up, whether or not the person is still taking the other opioid agonist, what's in their system, what's occupying the mu opioid receptors is buprenorphine. So you essentially carried out a cross taper, right? Without the potential for precipitated withdrawal. So that's really the idea, allowing buprenorphine to outcompete that full agonist and gradually take its place. So the key thing is that you do not need to taper down the full agonist during this time. Person can keep taking their full mu agonist. The buprenorphine itself will achieve this taper, right? It's going to do it for you. Still many protocols still recommend telling the patient to reduce the full agonist as much as tolerated before starting. Even I do that, right? I'll tell the patient as we're doing this, do your best, try to use as little as possible, right? But don't worry if you're not able to do so, right? So I'll give a quick case, 61-year-old male, long-standing history of opioid use disorder, interested in buprenorphine treatment, no other substance use disorders, but was extremely afraid of precipitated withdrawals, right? Of precipitated withdrawals. And we carried out, he just was scared that if we start buprenorphine, I've withdrawn from it before, and I don't want to do it. I don't want to go through it again. So we were able to carry out a successful transition using what's called the modified Bernese method. So what does that mean, right? What does the modified Bernese method mean? So this is the schedule I've included here, right? Which is commonly used. We actually went a little bit more gentle than this, where I started at 0.25 milligrams, but I basically prescribed the patient several strips of buprenorphine 2 milligrams / naloxone 0.5 milligrams. told the patient again to reduce the opioid use as much as possible, and to each day take the buprenorphine before taking any other opioids. And this is kind of how it's used. So you can see how gradually the dose builds up, starting very low, right? 0.5 milligrams once a day. So that's quarter of that 2 milligram strip. And once the patient gets to about 12 milligrams over a week or so, then we instruct the patient to stop the other opioids, because by then the buprenorphine is sufficiently occupying the mu opioid receptors, right? Again, with this particular patient, I started actually at 0.25 milligrams once a day, then went to 0.25 milligrams twice a day, and then went to 0.5 milligrams twice a day. So I added an extra day, right, essentially, just because the patient was so anxious, right? Some people have also used a low dose approach, where they're not going quite so slow as this, right? But they're going, starting with 1 to 2 milligrams every 1 or 3 hours, and then building up to 8 milligrams twice a day by day 2. But I think, so how do you pick between one versus the other? Both are low dose approaches, right? So how do you pick? So I think one of the key things is the patient still using opioids? I think if the patient is continuing to use illicit opioids in an outpatient setting, this is really becoming what's used the most commonly, right? Because it's the most gentle. On the other hand, when you see the patient, they already stopped using any opioids, and they're in moderate opioid withdrawals as manifested by a COW score of at least 13, maybe even 15, they've gone a day or two without using, right? Then you can be more aggressive. So you can start, this is one approach, sort of a low dose approach. And there is only, again, the research is lacking. The only study that's supporting this low dose approach is this one paper from 2020. And you can see that all it is a case series of 4 individuals, right? So there are no randomized controlled trials. There are no huge case series, right? So to be fair, I haven't used this approach much. I've generally opted for, because most of my patients, when I see them, are still using opioids. So I've gone for sort of some version of a modified Bernese schedule, a microdose schedule, right? So some pearls, right? Any protocol can work as long as it adheres to the basic principle that you're starting low, going up slowly, stepwise, while the patient is maintained on full agonist opioids. You can be flexible if the patient skips or delays a dose. It's not set in stone, and use those comfort medications aggressively, even as the patient is doing that. Establish a strong therapeutic rapport, right? As many are traumatized by previous precipitated withdrawal. Daily phone call check-ins, if outpatient can help. Education, direct involvement, right, of pharmacists, bedside nursing can all help. But there are some challenges to this approach, which is the retention, right? And I go to this, and this is again based on a real patient that I saw, 36-year-old female with identifying information change, history of severe opioid use disorder, was taking 7 or 8 blues daily for the past many years, history of trauma, past and current, diagnosis of PTSD, worked in a professional capacity, methadone was not an option, inpatient was not an option, and she'd had a history of many precipitated withdrawals with traditional buprenorphine initiation. So we attempted outpatient microdose initiation with no response for several weeks. I actually had presented this case to this ECHO several months ago, or maybe last year, if any of you remember. And then ultimately the patient was lost to care. She couldn't just never do it, right? So that brings us to something that Dr. Gadomski is a big champion of, which is the macrodose approach. And the rationale is actually exactly the opposite. We're not being gentle here, right? The idea is that we're giving enough buprenorphine quickly to overcome any withdrawals, precipitated or protracted, by achieving really high blood levels. So in outpatient setting, you might even do buprenorphine 8 milligrams every 30 minutes to every hour or two, right? Until they get to a dose of 24 or 32 milligrams. So you can see how aggressive you're being. Or you can do 24 milligrams followed by an injectable buprenorphine dose, if available, which is admittedly a big barrier currently because the sublocade is just not easily available. You can be even more aggressive in the emergency department or inpatient settings, right? Where a dose of 8 milligrams of buprenorphine every 5 minutes is even done, right? So you start giving buprenorphine 8 milligrams. If there are withdrawals, 5-10 minutes later, another 8 milligrams, 5 minutes later, another 8 milligrams. And again, in inpatient settings, we sometimes wind up going much higher, even than 32 milligrams, to get people over that initial hump, and use comfort meds aggressively. This is sort of a case series out of New York, where they took this approach where patients were withdrawing, they came in, they dosed them up, got them up to 24 milligrams of buprenorphine, followed by an injection of Sublocade, all on day one. And again, in this short case series, right, of 5 individuals, outcomes were generally pretty good. We're gonna start seeing some more randomized control trials happening. So I end with this vignette here that takes the macrodose approach. This is the one time we've sort of been able to do it at ASAP, to my knowledge, right, because of the availability of Sublocade. So this was a patient who already had Sublocade ordered, was available, but never got started on it, was continued to use other opioids. So we had some medication, injectable buprenorphine, with the patient's name on it sitting around, right? And again, I've changed all identifying data. The patient was continuing to take 40 to 50 tablets containing fentanyl daily via snorting or injecting. Had history of multiple unintentional overdoses, so was very high risk. Went to the care campus, but left before ever receiving her first dose of buprenorphine because, quote, I was just kicking too hard and they weren't doing anything, end quote. They tried a traditional initiation, just did not help her. She had tried microdose initiation on an outpatient basis, hadn't helped her. Continued to, never was able to stop fentanyl. Was not a candidate for methadone because of baseline prolonged QTC. Did have a history of diabetes, hypertension, PTSD. So we discussed multiple options. That's the other pearl. Involve your patient. She opted for a macrodose initiation with Sublocade, right? So we had Sublocade sitting around. So she took we ordered 3 8 milligram Suboxone strips. And she was instructed to begin at home after waiting 12 hours. And once the subjective opioid withdrawal scale was over 20. So she took 8 milligrams at 4 a.m., 8 milligrams at 6 or 7 a.m., and then came into the clinic. COWS was 6S presentation. We gave her Sublocade injection with no worsening of symptoms. The COWS had dropped to 4 after 1 hour. And there was no subsequent worsening of symptoms. And now she's just maintained on Sublocade 300 milligrams every 4 weeks, right? So instead of taking a week or so, basically we were able to get her onto the injectable opioid agonists, in a matter of about a day. So totally different approach. I think, again, involve your patient in this discussion, decision-making. I think my sense is much like Dr. Gadomski, that this makes a lot of rational sense. And we're gonna see maybe a lot more of this happening. But right now, the major barrier is the availability of the Sublocade. If, for example, a clinic was able to maintain a stock that could be given to any patient that it was appropriate for, then I think this can become a much better option or much more practical option. So that's where we are.